Welcome to the LDN Radio Show, brought to you by the LDN Research Trust. I'm your host, Linda Elseygood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. This show is sponsored by specialists in gastroenterology who are located in St. Louis, Missouri, and they provide sensitive, reliable patient care. They diagnose and treat challenging GI problems. Dr. Leonard Weinstock researches extraintestinal disorders, including restless leg syndrome, chronic pelvic pain, and rosacea. Visit www.gidoctor.net. Today I'm joined by Dr. Leonard Weinstock, who's one of our medical advisors. He works very hard in helping and supporting us. It's never too much trouble. We get questions that we can't answer, that we need a medical answer, and he's always there to help. Plus, he's amazing at the LDN conferences. Thank you for joining us today, Dr. Weinstock.
Linda, it's my pleasure.
And what was it you called me at the last conference?
Energy bunny? I don't know. You're a dynamo. How you find the energy, I don't know. But it's incredible. And obviously, the LDN's working.
It is. But most of the time, you don't see that I'm working from bed. I don't... if I use too much energy, I have to pay back. But anyway, what I would like you to tell us about is your recent studies that you have done with LDN. Could you explain that to us, please?
Well, we've got a couple cooking. Jill Cottle and I put our heads together on psoriasis because I had a tremendous case that... my physician's assistant saw, and I've been working with her to develop her interest in LDN, which is kind of see one, teach one, do one kind of phenomenon in medicine. And once you see the miracle of LDN, you can instill interest in others, and then they see it, and then there's no looking back. You just find the miracles that can occur, and which is limited by any other thing that you can do. So it dwarfs it many times with a simple, inexpensive, safe drug. So with respect to a patient, my nurse in the endoscopy area talked about her husband who had irritable bowel, diarrhea, abdominal pain, and terrible psoriasis. And actually, the nurse herself was on LDN for fibromyalgia and chronic fatigue and doing well. So we had her husband see Trish, our physician's assistant, who saw the psoriasis, elbows, knees, backs of hands, been going on for half of his life, not responsive to multiple topical medications, and he was afraid of immunomodulators and immune medications. And so she gave him the LDN, and we followed him, and he had a remarkable response to it. Now, as his dose was escalated, he had some headaches until he got up to the full anti-inflammatory dose, and then everything stopped. The headaches went away, the skin got better, the arthritis that went along with psoriasis got better, and his GI symptoms got better. And then at the LDN conference, I started talking about psoriasis with some of the people that, the clinicians there. And so Jill Cottle went through her records and found 12 patients. I found two other patients in my population. And so we have a net population of 15, where 10 out of 15 had significant improvement in their skin lesions. And this is now submitted for publication. And if it's published, it'd be a significant improvement. And Linda, you connected me with a professor from Brazil who has also found considerable improvement, and he's writing this up as well.
Oh, that's good. And it's all about the networking, isn't it? Getting all the LDN enthusiastic doctors to communicate, collaborate with each other. That is the only way it's going to move forward, I think.
I think so. I think there's a grassroots movement, so to speak. I've used that term before, and it spreads. It spreads underground. The root system spreads, and then the beauty of the green lawn comes up, and you can see just the benefits that patients have. And obviously, not everybody gets better. Nobody responds to any medicine perfectly. Otherwise, there'd only be one drug in class. You wouldn't see it anywhere else in terms of competition. But, what we want for our patients is an inexpensive, well-tolerated medication. And so I've used this drug in a number of situations, and extending it now to a condition called mast cell activation syndrome and postural orthostatic tachycardia. I just had a wonderful publication, case report in the Sarcoidosis Journal in November.
Hello?
Yes.
Oh.
So in that sarcoidosis case is very interesting because the pathophysiology of the medication makes so much sense. If we're regulating the T cell lymphocytes, which are at the focus of granulomas, which is part of sarcoidosis, that can affect the lung, the skin, the liver, the spleen, other organs involved throughout the body, we can really find a way of helping people. So this individual whose case was just published, and if people want to see it, it's available online through PubMed, PubMed.com. And the patient had dramatic improvement in liver and spleen infiltration. So, the radiographic improvement occurred, and it correlated with a dramatic improvement in energy levels. So that's part of this inflammatory process by using an anti-inflammatory drug like LDN vis-a-vis its promoting endorphins. We can help a situation that's often bombarded with steroids. Yes,
and steroids are not really that good for you, are they, long term?
No. And there's also a kind of a neat paper that just came out showing that in Crohn's disease, the steroid doses were significantly reduced. This was out of Norway, and they looked at 256 patients who had with inflammatory bowel disease who had been taking LDN for a long period of time, and they reduced the steroid dose, 44% reduction in steroid dose for Crohn's patients and 24% for ulcerative colitis patients. Overall reduction in total doses, total drugs in 12%. And in particular, a very bad drug we have is the immunosuppressant drugs that can cause lymphoma with chronic use. They drop the use 30% in their patients. So
wow.
That's a fantastic study by Rackness et al. Just came out this year, 2018.
Mm-hmm. So you're a gastroenterologist, and obviously I would think Crohn's and ulcerative colitis you see daily. But we know that you treat so many other conditions in your practice. Would you like to just describe, what your patient population is?
Well, it's a potpourri. I mean, literally, prior to 2005, before I got to know about LDN, it was straightforward. Patients with acid reflux and irritable bowel and inflammatory bowel disease and various motility disorders. And then I started seeing patients with small intestinal bacterial overgrowth and recognized a relationship to restless leg syndrome, which got me thinking about many other syndromes. And so success ultimately with LDN and restless leg syndrome by itself was exciting, and that allowed me to see patients, and look at their medicine lists when I saw them for their screening colonoscopy and say, oh, you're on Lyrica. Do you have fibromyalgia? And I say, okay, is it working for you? Generally say, not much. I said, would you like to try something new? And so then I'd have that patient come in for evaluation for treatment with LDN. So I would pull in patients with fibromyalgia, and then most recently, the difficult patients who are cursed with postural orthostatic tachycardia syndrome and mast cell activation syndrome have found me because of lectures I've given. And I've published on that, and just recently a publication came out in January on using low-dose naltrexone in combination with immune globulin and antibiotic therapy for patients severely affected by POTS and MCAS, mast cell activation syndrome. And then in that paper, I reflected on that LDN was partly effective for a number of patients on their own without any other major drugs. So that work needs to keep on going, and patients are finding me in that regard.
Mm-hmm. I know there are many patients that contact us after listening to you, asking how to get in contact, and then some get back to me to say that you weren't able to help them because they're not in the right area. Could you explain what your catchment area is, and do you do any of this telemedicine? Is it all face-to-face?
It really has become all face-to-face. I mean, my waiting list to get into my office is 2 to 3 months, and there's only so much I can do. And I think the thing that I can do is to have the publication so the patient can take the publication to their doctors, or most beautifully on your website, where it has our providers, take somebody, go to a doctor who's adept at giving LDN and get care there locally. Frankly, it's just very difficult still being active in colonoscopy, endoscopy, taking up 2/3 of my day, and then getting to the office and having patients, filling up the rest of the time, and then nighttime activities, keeping up with the practice and communications that I just can't do more. So I don't. So I've decided. I tried a few consultations over the internet, but they're best addressed by people who are non-proceduralists, perhaps, who maybe aren't as busy as I am. But I think my role in this LDN world is to recognize possibilities, to publish, to get the word out, because a lot of doctors don't trust anything that you bring in on the internet. But if there's a publication in a medical journal, then that carries some weight.
So really you are an educator, educating other physicians, really, which is an amazing thing, isn't it? Because, like you say, there are only so many hours in the day for you to actually help people. But if you can help train and educate other physicians who then can go on to prescribing LDN, and like you were saying about the grassroots movement, we will get more educated doctors who will then fill that need for all these people that are looking for LDN prescribers.
I think that's put beautifully. I think that's just what we need. I've encouraged my colleagues to come to the LDN Conference, and one doctor who has his own radio show and internet podcasts and so forth is interested, and it'll be great if he comes, because once he gets more comfortable prescribing it, learning about it, he'll be able to educate many other people.
Well, we certainly do our best, and from all the feedback that we've had from past conferences, the attendees absolutely love the Q&A sessions, and we have 5 hours, and we have a great panel of LDN prescribers who have been prescribing for many years. And it's such a unique opportunity for these prescribers to ask questions and get the answers. And I have got a question that I was sent yesterday from a pharmacist. He was giving a lecture to physicians, and he was asked a question, and I wasn't able to give him myself an answer because it has to be from one of our medical advisors. And the question he was asked was, why can't we just use 50 milligrams of Naltrexone to the same effect of increasing endorphins? What is the true benefit of low dose versus high dose?
Okay. It's a good question. The key thing is that we want to trick the immune system, and by using short-acting, low-dose naltrexone, it binds to the opioid growth factor receptors for just a few hours, and during that time, the body perceives a low amount of endorphins, and the body wants a certain amount of endorphins, and they want the activity, and so what happens is the cells start making more receptors by a factor of the naltrexone actually getting into the nucleus, and that circulates, increases number of receptors, and then the naltrexone that's on the outside of the cells where the receptors are, or in the nerve cells and even in the endocrine cells, pop off and go out in the urine, and then the cells start secreting more endorphins, and then in context with more receptors, you have a higher activity of the endorphin system. Whereas with narcotics or with long-acting blocking, these mu-opioid receptors are blocked, and they stay blocked, and endorphins don't increase. So it's all a matter of timing.
Mm-hmm. That is what I told him in an email, but I said I would get him an official response to that. So I'll let him listen to this recording. So that was a good answer there. And we've got the LDN app now, which has been relaunched this week as a monitoring tool for prescribers and for pharmacists to monitor their patients. And they have to have permission from their patient, and they can only see their patient's data. But we have PowerPoints on this to explain how secure and safe it is. But from the pharmacies that I've been talking to, they really feel that they are educators for prescribers to give them confidence to prescribe LDN. They're helping train them and to be there as a resource, and they gather information together, and we're going to try and centralise that. So all the information that a busy prescriber can need has this like Bible that these pharmacists are putting together, whereby if they have any questions of the efficacy or dosing, timing, they can then refer back to the pharmacist. So the pharmacists are really actively trying to promote LDN to the doctors as a possible treatment for their patients. So I think that's an amazing thing as well.
That's how I was introduced to it. Literally, a compounding pharmacist just a mile away came into the office in 2005 and said, "Dr. Weinstock, the LDN may be helpful in some of your patients." And I thought there was potential in changing motility and reducing pain, and which are big parts of my practice. So I started applying it to patients with irritable bowel syndrome in the beginning.
Mm-hmm. And I know pharmacists are equally as busy, but they seem to have more time to put the information together. And we have many pharmacists come to the conferences, which is also very good. And likewise, like that question just now, I know that you're always happy if anyone has a question that they don't know an official answer to. Even though you're busy, you're always there, and thank you very much for that.
You bet. Yeah.
So, as I was saying with the LDN app, do you think that is something that you would be able to use with your patients to use as a monitoring tool?
I think so. I've certainly recommended. In fact, I have a pre-populated verbiage on my electronic medical record, so that when I start LDN on a patient, they're given your website and they're given the LDN app information. Mm-hmm. I don't have a sense of how frequently, that's done. I think in terms of monitoring, if you can have a validated questionnaire or a way to track somebody's progress, it can be very helpful. And I think patients sometimes need to step back and see that, that symptom's less than it used to be, mm-hmm. and I'm doing better in that regard. Because many times with our complicated patients, their symptoms are so overwhelming that it's hard to have perspective.
Mm-hmm. And it's also very difficult when you improve gradually to actually see how far you've come. And when you are sick and your symptoms are getting worse, and every day there is something more that you can't do, or you have a new symptom, it's there in the forefront of your mind. But on the flip side, when you start to get better, you forget. I know I was talking to a friend and I'd said to her that I'd stabilised on LDN, and this was about 18 months after I'd started. And she said, "Well, what do you mean?" And I said, "Well, I'm the same. I haven't got any worse, but I haven't got any better." She said, "But you said to me your bladder was a lot better, this was a lot better, and this was in 6 months." And it was like, okay, I did continue improving, but it wasn't a big deal because it's just every day I improved a little bit, but you don't see the full picture until somebody makes you stop and look. And with the app, you can actually, there's nudges to say, just go into the app and fill in the details. It's, clicking a few boxes. And we're so grateful to Jill Brooke. She tweaked the app and the questions to make it really easy so that the data is of benefit and use to people who are trying to do clinical trials and studies. But you can do graphs and charts. So exactly what you were saying about people reducing medication, there's a medication page there, and some people with fibromyalgia take as many as 14, 20 different medications. And after being on LDN for like a year, you can see their chart where it's, dropped, 14, 12. Some people are only on 3 or 4, some only on LDN and everything in between. But it's a good feeling, isn't it, when you can see that your health is, I've forgotten the word I was going to use there, but you're improving.
Right.
And then it's a bit like losing weight, isn't it? Once you've started to lose weight, you feel good about yourself and you don't mind putting a bit more effort into it. And I think it's the same when people start to feel better. It makes them think, I can do this, I can improve myself. And as we had Jill on the other day, and she was talking about your study and trial, and she was saying, I think she said, you said syndromes were a dirty word and you were trying to eliminate them. She said that you didn't like syndromes. But
indeed, I mean, it's just like we weren't taught about syndromes in medical school. I came out to see that most of my patients who walked in the door had syndromes. They didn't have simple hypertension. They didn't have, quote, simple diabetes. It was irritable bowel syndrome and fibromyalgia and restless leg syndrome. If you total up the number of patients with syndromes, it's certainly easily half of the patients that we see. And in fact, there's some suggestion behind many of them. It's an allergic or immune phenomenon that might be explained by mast cells, these inflammatory cells. And anybody who has a mystery illness should look into mast cell activation syndrome. This is something that allergists are getting to know about, and immunologists as well. And hopefully at some point, general practitioners and other specialists will be able to say, oh, yes, I've got this patient with this severe symptom or syndrome that I'm seeing them for, but they have all these other symptoms affecting body parts body systems that could be tied together with one inflammatory mediator.
Mm-hmm. So what exactly is mast cell activation, and how would people know if they have it?
Okay, so the mast cell is one of the cells that lives in a precursor form in the bone marrow. And then when there's a trigger, such as inflammation, burn, or trauma, the mast cells are activated and come out and go to those sites to help orchestrate the repair, development of new blood vessels, and growth of tissue. But if the cells have developed mutations in their genetics and they come out, then those cells live a lot longer. Those cells are more jumpy and can release many different chemicals. Up to 200 chemicals have been isolated that are derived from mast cells, most notably things like histamine, which might give somebody hives, or if it's the cells are in the GI tract and the histamine or the tryptase, which is another common enzyme is secreted could cause abdominal pain and diarrhea, depending on the location. But when we see patients who have these syndromes, then we want to start asking other questions. So the common symptoms would be fatigue, muscle pain, and that's certainly, and brain fog. That certainly sounds like fibromyalgia. And indeed, many of those patients with mast cell activation syndrome have those symptoms. So I'll just list the most common symptoms in order. And fatigue, muscle pain, near faint, headache, hives, itching, numbness, tingling, nausea, chills, swelling of the body areas, the extremities, eye irritation, shortness of breath, heartburn, brain fog, rashes, abdominal pain, throat irritation, palpitations, sweat. Another one, the next most common, is environmental allergies. And you talk to somebody who's, when they're exposed to perfume, they get sick, they have headache or nausea. Then people can have fevers, chest pains, easy bruising. I can't tell you how many people throughout the years have told me that they bruise easily, and that may well be because of different chemicals that come out of the mast cells. And they have GI symptoms with change in bowel habits and swallowing disorders, problems with insomnia, flushing, visual disturbances, oral irritation, swollen glands, changes in their bladder with frequency, urgency, and pain, frequent and odd infections, poor healing, sinusitis, weight gain, inability to lose weight, dental deterioration, possibly due to acid reflux, weight loss, cough, panic attacks are common, multiple odd drug reactions, possibly due to sensitivity to the fillers, asthma, hair loss, depression, tremor, and suddenly feeling hot and cold. These are just 48 of the most common symptoms that people can have. And you can have some, all, or just a few. And then how do you diagnose it? Well, there's urine and blood tests, which are about 50% successful in picking it up. Partly, I think, is because you can have depositions in different areas, and it may not be enough to get into the bloodstream, to get into the, and also be present intermittently. You can have a biopsy of the gastrointestinal tract, like the duodenum or a terminal ileum, and look with special stains. You have to do a special stain to find the mast cells. So it's the major criteria would be 2 or more body systems with characteristic mast cell phenomenon, like I just mentioned, and a positive biopsy, or the symptoms plus demonstration of chemical evidence for mast cell activity, and then response to medical therapy. So those are the basic criteria for mast cell activation syndrome.
Mm-hmm. And are doctors trained in this in medical school?
Not at all. So, well, first of all, there was a case report in 2008. So just 10 years ago was the first case report. And then there was a case series in 2011. And then more recently, case series and discussions in 2014, 15, 16, and 17 about how to diagnose it and what the characteristics were. So does anybody want to Google this or do it on PubMed? or YouTube. Dr. Afrin, Afrin, is a wonderful educator and teacher in this field. But it's something where, since it's so challenging, once you start uncovering the answer for so many problems, somehow, that just makes people freak out. Doctors just don't want to deal with it. The doctors are a curious group of individuals. I always thought they would be, the most curious people and most willing to learn. But I've actually found that people are very conservative, and they don't like new things. They like to stick with what's comfortable. It's strange.
But that makes me think that if there's anybody listening who thinks they may possibly have mast cell activation, it would seem to me that it might be tricky to actually find a doctor who would help you to get a diagnosis. Is that right?
Well, I have to say that the allergists should be on top of this game. Mm-hmm. The internists, this is, again, all very new. This is, once again, a syndrome. It's not taught in med school. In fact, I volunteered to give a grand rounds lecture at the university, and they weren't interested. I don't know why. Wow. I gave it at my own hospital, and there was interest, and I've given it a lecture to the Washington University GI division, and there was some interest there, but it's the kind of thing that's going to take time to get in. But patients can suffer for decades with these symptoms. So I have been on board with this. But again, with the article that was just published, there's some good information, and Dr. Afrin's work is very good in terms of educating your doctor. So if you do think that you have this condition, by saying, okay, I have 5 different conditions, syndromes, and nobody's making sense of my IBS, my fibromyalgia, my interstitial cystitis, just to name 3 common severe syndromes. If, let's say, you just had those 3 things, you could say, okay, I want somebody to put this together. I think you gather together and the data on the internet and bring it into your allergist and say, can you test me for this? Can you refer me to a gastroenterologist and request biopsies of my duodenum? It's a simple endoscopy, or get cell blocks that were obtained from prior biopsies and have them stained for the mast cell with a special stain called the CD117 stain. Then you can start getting answers. And sometimes the treatment is relatively easy. I'd say that often, but sometimes simply recognizing and trying to stabilize the mast cell with certain medications and block the histamines can be very helpful.
Mm-hmm. And I know you have a waiting list, but if people would like to join your waiting list, how do they go about finding you? You're in St. Louis. I know you always...
Yeah, St. Louis, right. St. Louis, yeah.
And you'll
come to St. Louis. But again, I'm going to encourage people to, try to find local help and try to find an open-minded doctor. Those are the critical things that are going to get you through.
Mm-hmm. But if you have people who are on your doorstep, I mean, you have a website which is www.gidoctor.net.
.net.
Yeah. So if there are people that are close to you that you can actually monitor and keep your eye on, I'm sure you wouldn't mind them contacting you for an appointment if they're prepared to wait.
Right. You have to, in our country, you have to establish a patient-doctor relationship in the state that you practice to prescribe medications. So that's one limitation on telemedicine in general. So that's part of the reason why I don't do it on a regular basis.
Yes, because you need to be registered in every state.
I did in the past.
Right. Mm-hmm.
Yeah, you can't be registered in any state. No, I'm just licensed to practice in Missouri.
Mm-hmm. So anybody anywhere within the state of Missouri could potentially come and see you and you could treat them?
Sure, absolutely. Okay. And I see people from Kansas and different states for sure. They come down for consultation, and then we interact via internet through portal, email system. And then I'll try to encourage them to enlist, local help to get better and continue continuity of care locally.
Well, we've come to the end of our show, and thank you as always. It's always a pleasure and always educational. So thank you very much for being our guest today.
Oh, my pleasure. My pleasure, Linda, and keep up your great work.
Thank you. This show is sponsored by specialists in gastroenterology who are located in St. Louis, Missouri, and they provide sensitive, reliable patient care. They diagnose and treat challenging GI problems. Dr. Leonard Weinstock researches extraintestinal disorders, including restless leg syndrome, chronic pelvic pain, and rosacea. Visit www.gidoctor.net. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.